So I am super excited to chat with Dr. Brittany Henderson as we are going to talk about thyroid nodules, thyroid cysts. Going to be a really great conversation. So let me go ahead and dive into Dr. Brittany's bio here. So Dr. Brittany Henderson, MD, is a dual board certified physician in both internal medicine and endocrinology. She is a thyroid expert working to bridge the gap between functional and conventional medical approaches to thyroid care. It's a short but sweet bio. And welcome. Thanks for joining us, Dr. Brittany.
Thank you. I'm excited about the conversation.
Yeah, excited too. And yeah, let's get a little bit more into the background. I always appreciate a brief bio compared to spending like 5 minutes on a bio. But we were chatting before this, and I know that there's a lot more to your background. So if you could give, how did you start? What motivated you to become an endocrinologist? And you have a focus, not that you only do help people with thyroid cysts and nodules, even though that's a focus here.
Mhm.
But you do things that are different compared to a lot of endocrinologists, and including again just overall taking an integrative approach. So I guess how did you make that transition? Maybe that's rather than go over your whole history of becoming an endocrinologist, how you made that transition that I'm going to be doing things different than most endocrinologists.
Yeah. No, I was conventionally trained. I'm an MD by training. Did the classic T32 fellowship, at a major institution, did basic science research in thyroid, and then ended up joining the faculty. And my focus has always been on the thyroid. And a lot of that goes back to medical school and residency when I had a lot of good influences as far as endocrinology. I have a chemistry background. I really liked it. And so I just listen to my patients. I mean, that's what it boils down to. Thyroid care in the US is just not done well. Actually, thyroid care internationally is not done well. And by that, I mean people don't know how to diagnose it well. People don't know how antibodies affect thyroid symptoms for people. They don't know how to dose medication correctly. And there are millions and millions of people on thyroid medicine. I think it's one of the most prescribed medications in the US. I think over 20 to 25 million prescriptions a month. And it's just, in the conventional medicine world, it's a one size fits all approach. Everybody gets on the same medication and you're supposed to just be well. But that isn't the case in real life. A lot of the recommendations from the American Thyroid Association are very outdated. And so I just felt, a draw to help people in this field really try to do thyroid care right by looking at a full thyroid panel and by dosing things appropriately. And in our practice, we also integrate thyroid ultrasound for all of our patients. We really think it's important, just like a stethoscope is for a cardiologist. We need to see the thyroid itself, see how the gland looks, blood flow, whether or not there are cysts or thyroid nodules. And those are things that you can't always detect by a physical exam. So there are nodules that sit far back and you can't feel them. And I never want to miss a cancer. And I always want to make sure we know exactly what's going on with the full picture because thyroid care is complicated. Um, but just I started listening to my patients. I did a lot of my own research and started integrating a lot more functional medicine into my practice and integrating, supplements and vitamins and lifestyle measures and got microbiome work and looking at food intolerances. All of those things are so important in wellness and decreasing systemic inflammation, which helps the autoimmune process and the nodules too. And so that's what we do. We try to do thyroid care right. I think there's only one right way to do it. And that's what, we've integrated into both our brick and mortar practice down in Charleston, South Carolina, and our online practice.
All right, wonderful. So you do ultrasounds on every patient that walks through
Hmm.
your door.
Yeah.
Yeah, and that's good. When I went to, so my story, I was diagnosed with Graves' disease, and when I saw the endocrinologist, she palpated my thyroid, and she said that she doesn't think there's nodules, and she actually didn't recommend an ultrasound, and I asked her for one specifically. I'm like, yeah, it's not that I don't trust your palpation skills, but I'd still feel more comfortable. And I was paying out of pocket, so that might have been part of the reason too. But I mean, they're not crazy expensive, paying out of
No.
pocket for the ultrasound. So I was
It's
like,
so much information, and it's so
yeah,
worth it. Yeah. If
yeah.
you have somebody that knows how to interpret it correctly.
Yeah, exactly. So yeah, I'm with you that it's probably a good idea to get that thyroid ultrasound. It's, if you have a thyroid problem, it makes sense to look at it. But again, apparently there are some doctors, even endocrinologists, who don't order ultrasounds on all their patients. So
Yeah,
that's
I
that's
mean, in
great
the
that
same vein as like the stethoscope used for heart, I mean, like
yeah.
people image the heart all the time. They do echoes, they do, you know, cardiac caths. Same thing when you have a thyroid condition to look at it. It structurally, it's important. So,
Yeah. Yeah, no, I agree. So for those who are unfamiliar with thyroid nodules and thyroid cysts and the difference between the two, can you explain what thyroid nodules are and how they differ from thyroid cysts?
yeah, I get the question all the time whether a thyroid nodule is like a nodule next to the thyroid or within the thyroid. And a thyroid nodule is a accumulation of either fluid, which is what a cyst is, or cells, which is what a nodule is. It's more of a solid component within the thyroid gland. So within the structure of the thyroid gland, you can get these little bumps. You can sometimes feel them, and you can feel them on your own self if you look into the mirror, drink a glass of water, and swallow, because when you swallow, the thyroid moves. And so sometimes you can feel it. Thyroid sits right at the V, right at the base of your neck before your sternum. But not always. You don't always feel thyroid nodules. And the reason that people get these is because of, again, gland inflammation typically. So the thyroid gland receives blood flow just like every other organ in the body. And when there's inflammation within the thyroid itself due to Hashimoto's disease, Graves' disease, trauma to the thyroid, or if the thyroid's not functioning properly, like if somebody has iodine deficiency or iron deficiency, or lots of chemicals in the environment can increase the risk for these nodules to occur because of inflammation of the gland. The gland doesn't drain the way it's supposed to. The cells don't behave the way they're supposed to because they're inflamed. And then because of that, because there's not continuous normal drainage pathways, you can get an accumulation of fluid within the thyroid itself, which is a cyst, or you can get a proliferation or expansion of thyroid cells, which is what a thyroid nodule is. And those thyroid nodules can have gene mutations, which means that the cells start behaving erratically or irregularly, and that can lead to thyroid cancers or thyroid precancers.
And how common are thyroid nodules? I mean, imagine in your patient population, it's common because a lot of people come to see you
Mhm.
specifically for that problem. Again, you see other cases as well, but just in the general population, do you know the percentage?
Yeah, this it's super common and it goes up with age. So I always tell people 30% of 30-year-olds, 40% of 40-year-olds, 50% of 50-year-olds, and so on. And they've done actually autopsy studies where they found up to 80% of people who die, especially in their 80s, have thyroid nodules that they just pass away with, they never know about. The good news is that 95 to 99% of them are benign, they're not cancerous. But there are cancerous thyroid nodules, and it is one of the fastest growing cancers in the world, particularly among women. Women get thyroid nodules much more commonly than men do. But when men have thyroid nodules, we take it a lot more seriously because they are more prone to cancer and they're more prone to aggressive forms of thyroid cancer. We don't know why.
That's interesting because I know in general, or at least I'm pretty sure in general, most thyroid cancers there's like four types of thyroid cancers, I believe, right?
Mhm.
And like two of them are not aggressive, and most people have the non-aggressive forms. But I did not know that men with thyroid cancer, not all the time, but are more prone to having the more aggressive form. So I guess, I mean, either way,
Mhm.
whether it's a woman or a man, you got to look at certain characteristics of the nodules. Like, I guess let's talk about that. Like, how do you determine who gets a biopsy and who doesn't get a biopsy?
No, that's a good question. I mean, number one, if you have a simple thyroid cyst, meaning a fluid accumulation with no solid component, typically those are benign, like almost always. But they can be really annoying and they can cause issues, and we can get into that in a little bit. But when we look by thyroid ultrasound, we use several criteria to figure out who gets a biopsy or which ones we can just follow with serial ultrasound. The first criteria is size. So the American Thyroid Association and the American College of Radiology have determined how big does a nodule have to be before you recommend a biopsy. And so it's either, 1 centimeters, usually the lowest size, but it depends on the echotexture of the nodule, meaning on ultrasound, is the thyroid nodule dark hypoechoic, or is it bright hyperechoic, or is it mixed solid cystic? It just depends on what it looks like by ultrasound. And we have different criteria for size based on how it looks. So how dark is it? How big is it? Does it have suspicious features? Does it have calcium deposits in it? So we call those microcalcifications, which is a sign for cancer, or linear calcifications, rim calcifications. There's different types of calcium deposits. And then we also look at blood flow. So follicular nodules or follicular carcinomas, which is one of the more common cancers, can have a lot of blood flow by Doppler on ultrasound. And that is a more aggressive symptom as well, or sign, versus papillary thyroid cancers, which don't necessarily have blood flow. We also look at like the edges. If a nodule is very round and smooth versus a nodule that's very irregular looking or growing into muscle or trachea or other things. So there's lots of criteria that we use, and ultrasound's the most sensitive modality to look at this. Better than MRI, better than CT scan, which is why we use it in the practice. It's so easy, it's cost effective, it doesn't expose anybody to radiation, and it gives us a lot of information. So we do that, and then we recommend biopsy, or we recommend serial ultrasound to monitor for growth. Even benign nodules can grow with time. And there are so much that has come out in the last 5 to 10 years for personalized medicine to figure out risk stratification for patients and how aggressive might a cancer be versus how not aggressive a cancer might be. And a lot of that's using genetic testing. So there are genetic tests that we use when we do a biopsy, which can tell us if the nodule has a gene mutation that is suspicious for cancer or not. And that, there's so many decision pathways, but really it's come a lot farther than what we used to do, which was just to suggest everybody have it removed. And before you remove a very important endocrine gland, which is really hard sometimes to dose and get right and mimic with our imperfect human medicines, it's worthwhile to get, a second opinion or a third opinion, or really figure out if this is the right course of action before making a dramatic decision like surgery.
Yeah, makes sense. So if you do a thyroid ultrasound and you detect nodules and you just decide that the person doesn't need a biopsy, it sounds like you do follow up with another ultrasound in the future, I don't know if you do that across the board, just to make sure that the nodules aren't getting bigger.
We do, yeah. So usually it depends on the size of the nodule and the appearance as to how often we follow that.
Okay.
Excuse me. Primarily, it's about a year that we look.
Okay. So usually a year. Any indication sometimes for 6 months if
it looks hypoechoic or dark, or if it has suspicious features and it's smaller than a centimeter, yes, we will recommend a closer follow-up, like the 6-month mark. If there's a nodule that's actively growing and we have a fearful patient that isn't a fan of needles, which who is, but we sometimes will do a closer follow-up in like 3 to 6 months just to make sure we're on top of it. And then if somebody does have a thyroid cancer history, and we always look by ultrasound every 6 months for the first 2 years, and then every year after that. But if we see anything like lymph nodes, which thyroid cancer primarily goes to lymph nodes when it spreads somewhere, then we either recommend biopsy of the lymph nodes, or we recommend serial ultrasound surveillance every 3 to 6 months, depending on the aggressiveness of the original tumor.
Okay, and then you said you also, when you do a biopsy, you do genetic testing as well, just to determine, what type of cancer it is, or
Yeah, so if it comes back as a indeterminate nodule, so there's 3 ways a nodule can come back after a biopsy. There's benign, which is the most common, cancer, which is the least common, or in the middle, indeterminate. That happens about 10 to 20% of the time, and it just means that the cytologist can't say 100% that there's a benign nodule here because the cells overall look good, but there are some funny features. They're either bigger than normal, or they're inflamed looking, or they have some features suspicious for thyroid cancer, and they can't say either way. In that situation, we collect a special test, which basically runs all of the known gene mutations for thyroid cancer and gene fusions and other things. And then we can tell somebody, okay, you had initially a 10 to 20% chance of a cancer. Now we ran this gene test, and now it's telling us that you have a genetic mutation in the tumor that says that you have a 50-50 chance or a 95% chance of cancer. And that really helps us to risk stratify people and really give them a good idea of whether they should have half the thyroid removed, the full thyroid removed, lymph node dissection, depending on the aggressiveness of the mutation. And we run that mutation as well for suspicious for thyroid cancer patients too, because it does help with understanding how aggressive the tumor might be.
okay. So, and if someone comes back and their ultrasound, I mean, not the ultrasound, the biopsy, you conclude that it's benign. You don't do the genetic testing. Is that correct, or?
That's correct, yes.
Okay. Okay. Just wanted to clarify. And then, what are toxic thyroid nodules?
So toxic thyroid nodules are just nodules that are overactive. It sounds terrible, and it actually feels terrible for people because the thyroid is then no longer under the control of the brain and the pituitary system, which is the master gland that is supposed to be tightly regulating thyroid hormone production. But sometimes, if thyroid nodules have been there for a long time, they develop mutations that affect the TSH receptor. So instead of allowing the pituitary gland to signal with a TSH signal to the thyroid nodule to produce thyroid hormone, the thyroid nodule starts producing thyroid hormone all the time by itself because it hits the on button for the TSH signaling and just always is producing thyroid hormone. But it doesn't produce thyroid hormone in a good way. It just basically spits out thyroid hormone randomly whenever it makes some. And that can feel like a person's having hyper symptoms, hypo symptoms. They can feel like terrible. I mean, it doesn't feel good. And over time, especially in older patients, people can be at a higher risk for osteoporosis because of the thyroid just secreting extra hormone. They can have a higher risk for atrial fibrillation or heart arrhythmias because of that. And it just really contributes to all of the symptoms of thyroid: heart racing, jitteriness, anxiety, insomnia, weight gain, fatigue, brain fog, all of the different hyper and hypo symptoms because of the thyroid nodule behaving irregularly.
Okay. And then, whereas thyroid, just a regular thyroid nodule, thyroid cysts are quite common, is it safe to say that toxic nodules are not as common?
I would say that's probably true. I would say I see toxic thyroid nodules, which, by the way, most toxic nodules are benign. They're not cancerous typically. Some can be, but most of them are not. I see those primarily in regions where people grow up with not as much iodine, or they've had long-standing iron deficiency. And that's because the nodules typically have been there for a very, very long time. Those patients who are like nutrient deficient, many times will have them from childhood or teenage years, and they're the ones that typically develop them. But of course, there are many factors and variables, and we don't know every single variable that predisposes a person to have a toxic nodule. You can have, by the way, more than one. You can have a toxic multinodular goiter, which is many nodules that are overactive. But typically, these are patients that grew up not eating seafood or seaweed or they grew up in the mountains where they didn't have a lot of fresh fish or iodine exposure, or they've had a lot of heavy periods for women, haven't eaten a lot of red meat, and they're iodine deficient or iron deficient. So those are the people I see it most often in.
Okay, and then hot and cold nodules. So can you and I don't know if you do the uptake test at your clinic?
Not at the clinic. Usually, a nuclear medicine department at a hospital is who does that. There are some freestanding clinics that do it, but not very many. And so, a thyroid uptake scan basically is a scan where the person ingests iodine. It's not radioactive iodine, it's just iodine with, it's attached to a radiopharmaceutical so they can actually image the thyroid. But basically, what it's doing, it's concentrating primarily in hot nodules and not in cold nodules. Cold nodules are nodules that do not pick iodine up very well. And so, those are nodules that don't make thyroid hormone. But with a scan, you can actually figure out, okay, is a nodule hot on one side of the thyroid and then maybe cold on another side of the thyroid? That can help you understand, does a person, if they have hot nodules, require treatment just on one side of the thyroid gland? Do they need their whole thyroid removed if there are hot nodules all over the place? And it can really help you identify where the problem is. But we use thyroid uptake scans all the time, not just for nodules, but for Hashimoto's, a form of Hashimoto's called hashitoxicosis, for Graves patients. It is helpful when it's helpful. Even if it's normal, sometimes it doesn't completely rule out a problem, but for toxic nodules, it is a helpful test.
Okay, good to know. So, so for those with Hashimoto's, Graves' disease, so you recommend for pretty much that category of patients
Yeah,
to get the
those are
uptake.
the
Yeah.
people, yeah, that it really helps with. Or people who have something called acute or subacute thyroiditis, which is basically where you get a viral infection like COVID, for
Mhm.
example, and your thyroid spits out all its thyroid hormone, you get really hyperthyroid. The uptake scan will look like very low uptake on the uptake scan because it's just been completely destroyed by the virus. Well, really by the immune system. And we see that occasionally as well.
Speaking of subacute thyroiditis, I'm just curious, what's your treatment approach? Because usually with subacute thyroiditis, they're transiently hyperthyroid, but eventually become hypo. So I don't know if I know some endocrinologists are hesitant to give antithyroid medication because they know eventually the person will become hypo, but at the same time, you want to do things to manage the hyperthyroid symptoms. I don't know if you recommend antithyroid meds or just a beta blocker, or what approach do you take for that?
I mean, antithyroid meds in subacute thyroiditis don't work because they work primarily on stopping the thyroid from making thyroid hormone. You could use PTU because it stops T4 to T3 conversion, but I don't usually do that. For somebody who has subacute thyroiditis, we just treat symptoms. So we put people on beta blockers to treat heart rate issues. We put people on prednisone if there's pain, but it's really like waiting it out and just kind of letting the disease take its course. And then typically people will become hypothyroid, but many of those people can go back to euthyroidism. They can go back to normal thyroid function,
Yeah.
but it takes a little bit, 3 to 6 months. It's a thing. We see it not very infrequently.
And then you mentioned iodine. So iodine, very controversial in the worlds of thyroid health, but you mentioned that it could be a factor when it comes to thyroid nodules and even toxic thyroid nodules.
Mhm.
So I guess your approach when it comes to iodine, because there's a lot out there. There are some practitioners who recommend massive amounts of iodine supplementation. There are
Mhm.
others who recommend the opposite, to like really restrict iodine supplementation, and really both hyperthyroidism and Hashimoto's. Again, it depends on the practitioner, but it's not just hyperthyroidism. Some suggest that with Hashimoto's too. So, yeah, what are your thoughts when it comes to iodine and hyperthyroidism, iodine and Graves, iodine and Hashimoto's?
So iodine is one of the micronutrients that follows the Goldilocks rule. It has to not be too much, it has to not be too little, it has to be just right, and it's patient specific. So, in thyroid nodules, most of the time, I recommend just like the recommended daily allowance of iodine, I'm sorry, unless somebody is iodine deficient, and you can measure that typically in like a 24-hour urine iodine. It doesn't make sense to check serum iodine levels in people because it's transient. You know, if you eat something that has a big load of iodine, your serum levels will go up acutely, but then the iodine is transferred into cells. So a serum level doesn't really mean anything. A urine level can be helpful. And in people who are iodine deficient, people like who don't eat seafood or are vegans or vegetarians, they tend to get thyroid nodules and goiters or enlargement of the thyroid because the thyroid is working overtime to try to make thyroid hormone with only having a little bit of iodine to make it. And so in those situations, we do recommend a little bit higher dose of iodine. And by that, I don't mean like 12,500 micrograms. I mean, 300 to 500 micrograms short term. And then the recommended daily allowance for adults in the US is 150 to about 225 or 250 micrograms, higher for breastfeeding or lactating women. In autoimmune thyroid disease, it depends. So we know there is a effect called the Wolff-Chaikoff effect in Hashimoto's, where the thyroid tissue is not normal. It's being attacked by the immune system. And too much iodine in a patient who has Hashimoto's disease can stun the thyroid tissue and actually make it not produce any iodine, just stop completely. And we know that too much iodine can actually worsen some of the Hashimoto's antibodies, like thyroglobulin antibodies, which can get tagged with iodine and alert the immune system to worsen the autoimmune attack on thyroid. So in those situations, we don't recommend an excess amount of iodine. I never recommend like super low iodine states. I don't think that really helps to reverse things. A recommended daily allowance 150 micrograms, whether it's through a vitamin or through just normal exposure, is fine. And there is data as well to show that Graves patients, hyperthyroid patients, do take iodine and their glands are overactive. So they take the iodine and their thyroid glands make tons of thyroid hormone. So in order to help get Graves into remission, usually we do try to restrict too much iodine. We try to avoid it or reduce it. So in those situations, a lower iodine diet for a short time might help get into remission. But once remission is achieved, normal iodine intake is probably fine. So that's my approach. I think it's really highly personalized medicine. It really depends on the patient's clinical picture. But I don't have a lot of patients where I use like a ton of high dosed iodine to try to help.
Yeah, no, that makes sense. And then for thyroid nodules, really the same approach. Like if someone's, I guess it depends if it's a toxic, not, I don't know if it depends on the situation, but as far as like, since there's a chance that in some cases, not all cases, but some cases, an iodine deficiency can be a factor for thyroid nodules. I don't know if you recommend, you mentioned sometimes urinary iodine testing to see
Mhm.
if that might be an underlying factor. And if it is, yeah, you don't go to the massive amounts of iodine, but maybe have them take a little bit more then.
Yeah, I think if they're deficient and they have a thyroid goiter or multiple nodules
Yeah.
that are not toxic, that are just normal nodules, it makes sense to go ahead and give them more iodine. Maybe not like a crazy amount, but higher than the recommended daily allowance. Toxic nodules have been shown in the literature that after a high iodine load, they can really start like revving up, and they use that iodine to make lots of thyroid hormones. So that
Mhm.
can actually cause, quote, thyroid storm or excess hyperthyroidism. I've never seen that. Usually, thyroid storm is reserved primarily for Graves patients, but it's theoretically possible in a big thyroid nodule that's toxic that it uses a big iodine load to make a lot of thyroid hormones. So I don't usually recommend high iodine loads for people with toxic nodules.
Okay. All right, let's talk about treatment. So, as far as conventional treatments, regarding most endocrinologists, it's I mean, most of them don't need treatments. Like most
Mhm.
are benign and they won't do anything. But if they meet the criteria of the certain characteristics that you discussed, then you typically it's partial, or I mean, not as common to see partial thyroidectomies these days. A lot of times it's just get the surgery, and obviously with cancer, I guess it's understandable, but
Mhm.
um, sometimes I see even in cases where someone it's benign, but if it's a really large thyroid nodule, they'll recommend for the person to get surgery. So that is that pretty much a conventional approach? I mean, either surgery or no surgery, would you say?
I would say that's true. I would say that most conventional endocrinologists will recommend, total thyroidectomies for most people. Well, knowledgeable endocrinologists who specialize in the thyroid will make a less aggressive approach to this. So they will recommend more of the hemithyroidectomies if it's a benign nodule, like if it's a big nodule causing a person to choke or feel like they're, choking. They'll recommend just half. Or if it's a low risk thyroid nodule, meaning that we did the biopsy and we have the genetic test and we know that the mutation is typically low risk, we'll recommend just half of the thyroid. I think that's the better approach. That's the approach that we take in our practice. We always try to preserve as much thyroid tissue as possible because it's a big deal to take out the thyroid gland. We used to just, say, oh, it's fine. We have Synthroid, we have replacement medicine, but replacement medicine is not the same as your own endogenous endocrine gland, which basically controls everything. There's thyroid hormone receptors in every bodily system, all of them. So before removing a very important organ, it makes sense to really think through that. And even in thyroid cancers, for example, in my practice, if it's intrathyroidal, meaning it's not growing outside the thyroid, and I don't see a lot of lymph nodes, I always do the ultrasound before surgery to make sure I know what to tell the surgeon as far as if there are any lymph nodes underneath the thyroid that have cancer over to the side in the lateral neck, and how to direct them as to how to perform the surgery correctly, because it's very important that the surgery be done right the first time. But even for thyroid cancers that are within the thyroid, they don't have a lot of lymph nodes present, we sometimes recommend half the thyroid, hemithyroidectomy. And I don't always recommend a completion thyroidectomy, even if it's, a higher stage or if there's a couple lymph nodes present, because I love to be able to preserve thyroid function for patients and minimize the amount of tissue that we're removing.
Yeah, that's wonderful. Again, there aren't a lot of endocrinologists who do that. So it's good to know that if absolutely necessary, of course, you'll recommend a complete thyroidectomy, and there is a time and place for that,
Hmm.
but you'll do everything you can to try to preserve, some of the thyroid tissue and recommend like a partial thyroidectomy if you feel that's warranted. So
Right.
that's good to know. I didn't realize in cancer too. If again, probably just because the approach is usually just remove the whole thyroid gland, and I don't hear about endocrinologists who just try not to do that. So that's great that there's that option. So wonderful. And then, so I wanted to talk about alcohol ablation because, again, that's something that most endocrinologists don't do. And so that's something that you offer. So, can you discuss what alcohol ablation is, when it's indicated?
Yeah. So, I mean, along the same lines, we like to use minimally invasive approaches to care. We want to not disturb regular normal thyroid tissue. If I see a thyroid that looks beautiful and it's working optimally, I do not want to remove it. Even for thyroid cysts, which I had said, if it's a simple cyst, meaning it's just a pocket of fluid, and we see that on ultrasound, that's how we figure out if it's a cyst. Then the best way to approach that, the most effective way without disturbing any thyroid tissue or having to go on thyroid medicine lifelong, is a minimally invasive approach called alcohol ablation therapy, or sclerotherapy is the other name for it. And not every endocrinologist does this. There are very specialized endocrinologists that know how to do it throughout the US. I think they have some at the Mayo Clinic. There are some specialty practices throughout the US, but very few people are trained on how to do it, unfortunately, because it's a very effective treatment option for thyroid cysts, and it's very low risk as far as any complications. But basically, the way that we do it is we drain the thyroid cyst. So if you have a cyst, your endocrinologist can just drain it. They can just take a needle, stick it in the thyroid cyst, and drain off the fluid. And many times in big thyroid cysts, especially, which are causing people to feel like they're choked or you can see it, many times that cyst fluid just comes back. And the reason it comes back is because the cyst probably has been there for a long time and has a big cyst thick wall that stops fluid from being allowed to be drained. So it just fills back up because of the drainage pathways are all messed up. With alcohol ablation or sclerotherapy, we do the same thing. We drain it. But at that same time, we will inject the cyst with pure alcohol, ethanol. One of the side effects is feeling a little bit weird, but that doesn't usually happen. It stays within the cyst wall, so you shouldn't feel any effect from that. But the alcohol basically kills off the blood supply to the cyst wall, so that the cyst wall involutes within itself over time and the cyst goes away. I just had a patient that we did this on a couple months ago. This person came back yesterday to my clinic, actually, had a huge cyst, trouble swallowing, had it drained multiple times, and it just kept coming back. 65 cc's, which is a big, big nodule. I mean, that's a lot of fluid in somebody's neck, and this is not a big space. We did the alcohol ablation, one round of it, and it came back yesterday, and it's down to less than 2 cc's, 96% volume reduction, no symptoms, doesn't see it anymore, completely normal thyroid function, not having to be on thyroid medicine. So that is a very easy, minimally invasive way to take care of this. And conventional doctors, a lot of times, if it comes back after it's been drained, will recommend surgery. And that is, I think, not the right approach to these cysts. This is such a better option for people.
Yeah, no, that sounds amazing, and just yeah, I mean anything you could do to save the thyroid, and it sounds like a low risk too as well. Like, are there any
Yeah.
contraindications or?
I always tell people, the main complication would be if the alcohol leaks outside the cyst and causes like pain at the site, or theoretically affects the nerve that goes to the voice. So you get hoarse voice. That would be transient. It would come and go. But I've never seen that ever because the cyst fluid stays within the cyst. So the likelihood of it leaking out should not happen. Most patients don't have any pain with it because there's no nerve endings within the thyroid, so it doesn't hurt. And it takes about 15, 20 minutes and you're off to the races. So really minimal side effects, if any.
And you've been doing that for quite some time, correct?
I've been doing that procedure now for almost 10 years
Wow.
with my practice, and we do it regularly. We have people who fly internationally to come see us to have it done because, again, it's hard to find people in your local area that know how to do it or know how to do it well. And it's so easy and it's so effective, and it's just how it should be the standard of care, honestly.
Yeah, no, that's wonderful. And is it just for cysts, or can it help with nodules as well?
It's just for cysts. Sometimes I have people, if they're interested, like send their images to me, and I can look at them on a secured email. I can provide that in the show notes, just so that I can make sure it's a candidate before they travel. But it usually is just reserved for cysts, not for solid nodules. We do use it for some isolated thyroid cancer, not lymph nodes. Usually that's best reserved for older patients who are not surgical candidates, because surgery to remove a cancerous lymph node is probably better. But it does work effectively for cancerous lymph nodes as well. If somebody only has like one or two, if they have lots, surgery is better. But for solid nodules, it's somebody could consider something called radiofrequency ablation, which is a different minimally invasive option for these solid nodules, because solid nodules can't be drained. They're full of cells, and they're usually more vascular, so they have a lot of blood flow. With radiofrequency ablation, the way that works is that the needle tip has a positive and a negative electrode. And so the physician will place that needle tip within the solid nodule, and the positive and negative electrode cause heat. They're like thermal ablation pretty much. And that heat kills off the blood supply from the inside out and causes the nodule to involute and go away. It's more invasive, a little more invasive, and a bigger, longer procedure than the alcohol ablation. But for people who have solid nodules and don't want surgery, or they want to preserve thyroid function, or if they have a toxic nodule, which is the overactive nodule, then radiofrequency ablation can sometimes be a minimally invasive option to fix that.
Okay. So the alcohol ablation for cysts, if you have a solid nodule, then maybe look into radiofrequency ablation,
Mhm.
including in some cases toxic nodules. And yeah, that's great. And so, unlike draining a cyst, then when you use the alcohol ablation, then it's unlikely to come back.
It's unlikely to come back, although if you start with a cyst that's really big, and by that I mean over 20 cc's. So that's kind of the cutoff in the literature. If it's over 20 cc's, it's more likely to need a couple courses of alcohol to kill it off. And that's just because those bigger cysts have thicker walls. And so the alcohol doesn't always get to the throughout the whole cyst wall, and it can still accumulate. Usually it'll go down after the first treatment, but and I usually, with those huge cysts, I can do up to 3 treatments, and usually by that point it will have shrunk enough that the patient says, "This is great. I feel I don't have any symptoms anymore. Even if it's still there a little bit, it's okay." And we can always do it down the road again. But yes, for most nodules, it works the first time.
Okay, so then you just gave an example of a patient. I think you said it was 65 cc's
Mhm.
was the cyst went down to 2 cc's, I think. So what's the follow-up procedure? Like, is it like a few weeks later you like reevaluate, or like a month later?
Usually, I give it a good 2 to 3 months before we reevaluate with the ultrasound, but the patient should notice an improvement the minute that they leave the door. I mean, like, they should notice that it's gone, that they're able to swallow again, that they don't feel like they're being choked. And that should persistently get better because the thyroid cyst over time involutes. So it takes about 6 months to see the final result. I usually look at that halfway mark, and I'm happy when there's at least a 50% volume reduction in the cyst, but usually we're getting 80 to 90% reduction in cyst, in the cyst. It's still going to be there, but it will have involuted enough that it's not going to do anything. Sometimes it goes away completely. Those are really, really good results. But I always tell patients too, after you've had that procedure, if you have another endocrinologist look at it with an ultrasound, they're going to say, "Oh my gosh, this looks terrible. You have thyroid cancer." And you just have to know that it looks involuted. It doesn't look like nothing. So just education of outside providers that are not comfortable or familiar with alcohol ablation by the patient, even sometimes, is helpful to prevent additional workup that's not needed down the road.
Yeah, I mean, it's great to have an alternative because in this situation, if that person went to a conventional endocrinologist with 65 cc cyst, they're probably going to be told to get a thyroidectomy. Is that correct? Or
Yeah, most of the people that come to see us have been told to get a total
yeah,
thyroidectomy or at least a hemithyroidectomy, and they don't want to lose their thyroid. So, smartly and after some research, they decide to pursue another opinion, and it usually is a great option for people.
yeah. All right. Well, you covered a lot. Is there anything else that I should have asked you that I didn't ask you, or anything else you want to share when it comes to nodules or ethanol ablation?
Yeah, I mean, we are happy to, like I said, look at cysts if patients want me to look at their images. I usually want to look at the images, so I'll supply that information for people. And then also, if people want to learn more about thyroid nodules, about goiters, about iodine deficiency or iron deficiency or anything thyroid, we just launched a new online patient course. It's a 6 week learn at your own pace patient course directed to people. From everything from what is the thyroid, where is it located, how do you feel for thyroid nodules, How do I know if I'm on the right thyroid medicine? We talk about all of that. We talk about Hashimoto's, Graves' disease, antibodies, lifestyle measures, all of it. And it's called Everything Thyroid. And we will supply the link to that in the show notes if people want more education, if they want to be more knowledgeable about their thyroid issues. I think it's a good starting place as well.
All right, yeah, definitely we'll make sure to put it in the show notes. And then, so you have, as you said, you have a brick and mortar in Charleston, South Carolina, and that website is charlestonthyroidcenter.com. And
That's
then
right.
you have, yeah, and then a virtual practice, mythyroiddoctor.com, correct?
That's all right. Yes. In the virtual thyroid practice, we see patients in select states all throughout the Southeast. So we're in the Carolinas, Tennessee, Virginia, Florida, Georgia. We are also licensed in Minnesota and Arizona. So if patients are located in those states or if their loved ones are located in those states, they can see us and get our professional opinion and treatment from us online without having to come in person.
All right, that sounds great. Any other places, Instagram, Facebook? I don't know if you're on social media.
We're on social media. Yeah. Our biggest presence is on Instagram. So we provide videos all the time about thyroid care, about thyroid nodules. We have a whole series actually on thyroid ultrasound and thyroid nodules on our social media. But you can follow us. It's Dr. Henderson MD. It's Dr. Henderson MD. And that's for Instagram. We're also on TikTok and Facebook.
All right, wonderful. Well, thank you so much, Dr. Brittany. This was amazing. Just you provided some great information when it comes to nodules. I'm glad you're also trying to help save people's thyroids through the alcohol ablation. Keep up the good work, and yeah, we'll definitely have to have you back on the podcast in the future.
Yeah, it was so much fun. Anytime we can spread awareness and knowledge for people and really help change the course of their health, I'm all for that. That's great.
Yeah, I agree. Again, thank you so much.
You're welcome. Thanks for having me.